All right, I think starting to slow down. I think we have um, a nice little group here this afternoon. Thank you for joining us. My name is Christine Merriman. I am the PDN and Home Health Policy Advisor for the Department of Healthcare Policy and Financing. And with me to help me run the slides and will be helping watch the chat and answer questions if need be is my counterpart, Paul Hutchings. Um, you have probably ran into either one of us if you've ever sent a question to the home health inbox or been on any of these meetings. Paul and I are a team here at the Department of Healthcare Policy and Financing. So get to the next slide here. So before we start, we typically start all of our meetings and trainings with the department's mission, which is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. So this is our agenda for today. Our PDN program and background. The rule revision goals, if you weren't a part of that, we want to just go over that briefly, review some stakeholder engagement, and then talk about the summary of changes to the rule. And then we're going to do something a little bit different and give some suggested implementation for the changes for providers in the home health world as just recommendations and suggestions on things to look at. And then next steps after that. I do want to say that we are recording for those that just joined, so please make sure not to use any protected health information or personally identifiable information. When you're speaking, please identify yourself when you're speaking. We want to know who you are and who you represent. We'll do our best not to try to not use acronyms. And we welcome all of the voices, insights, concerns. We want to keep this positive and professional and courteous and respectful to all involved. And please know that that we're going to stay focused on PDN today. If you have other questions, you can submit them in the chat, and we will copy those down and get back to you. Or you can always email the home health inbox. And we can put that address in the chat should you have other questions that do not pertain to PDN. Okay, next slide, please. All right, so most of the folks on this call know that private duty nursing is a Health First Colorado member benefit. Services all ages, pediatrics, adults. There's no age limit. And currently we're actually approximately about 1,000 members utilizing the service today. The PDN program provides skilled nursing through a registered nurse or a licensed practical nurse, an RN or an LPN members through a skilled home health agency. This is just a background of what has happened with PDN in the recent past. So 2019, 2020, the PDNs were paused in part due to the public health emergency. In 2021, we turned them reinstated PAR reviews for medical necessity. But then in 2022, there was a rollout. It started in 2021, and by 2022, we began to hear from families and advocates that they had concerns about the PAR process and how reviews were happening, and lots of questions on the benefit itself. So we instituted an administrative PAR approval beginning in October of 2022. We had an action plan that we worked through with stakeholders that included this PDN rule review and the revisions, which started in February of 2023. The administrative PAR approval process ended in April of 2023. And then after almost 12 months, actually a little longer, of stakeholder engagement, we came to a decision, an agreement on PDN rules that were presented to the Medical Services Board and were approved. And these rules went effective yesterday. So our goal with revising these rules is really to collaborate with the stakeholders to identify what was unclear, what was outdated, what was confusing, what was causing the major headaches for the members who utilize this benefit, as well as the home health agencies that provide this service. And it's been quite some time since we've actually gone through and done a head to tail rule revision. So we restructured and reorganized some sections so that it would be for flow and clarity. And then we wanted to hear the stakeholder community's thoughts and ideas, and we contribute in their contributions to the rule revision were so valuable that a lot of the things came directly from stakeholder engagement, the changes and revisions. So we had various levels of stakeholder engagement. And so when I say that, I want you to understand that it wasn't just members and families and advocates and providers, but it was also our program integrity staff, the Department of Public Health and Environment, the Attorney General's office, the Board of Nursing. So we had partners from throughout the community that have any engagement in private duty nursing to have their view heard, and their comments considered, and we really appreciate all of the involvement that we had throughout this process. All right, so we're going to go to a crosswalk of changes that we developed and will be put onto the private duty nursing website for you to review later. Maybe.
I might have to switch screens. It changed on my screen, but it doesn't look like it's changed on yours. So give me 1 second here.
Are there any questions so far? Okay. I'm going to take silence in this instance. It's good. So this document will be out on the PDN website, and it is just an outline of all the changes that we made to the rules section by section, and then it correlates to the new, like we added the definition of designated representative. And so that is there at 8.540.1.a. So I'm not going to read through every single revision that was made and where it's located, but this is we thought it would be nice to see where things have changed and have an easier time finding it now that the red line is gone and the rule is revised out on the CCR. So goes through section by section there and explains what was revised, what stayed, what language was removed. So that will be posted. Any questions about that document? Is that helpful? Do you think it will be helpful? I'm trying to make sure that this is as easy as can be for a rule change. Thank you, Megan. Appreciate that.
Do you want to swap back to the presentation?
Actually, can we look at the process flow, or maybe we'll do that in a minute. But also in this document, you'll see that we have a process flow, kind of mapping out the process of the PAR, because that was kind of confusing. We also have a handy chart here on the timeframes of when things are due. And I've highlighted the things that are new. And then there's also a documentation resource guide that will be attached as well. This is documentation that is required currently, and then some suggested to documentation that could be helpful in painting that picture for the prior authorization. So all of this will be out and available, and we'll go through some suggested implementations regarding this as well. So we can go back to the
Dean, you have a question in the queue. They'd like to know when will this be available?
As soon as we make sure that it is accessible, and all those changes are good on the so that everyone can access this. It should be no later than the end of this week. Okay. We can go back to the presentation. Thank you, Paul. So the next slides are just summary of some of the revisions that were made to the PDN rule. I tried to pick out most of the larger changes that could affect operations and how policies are and procedures are followed in the agency. So, and there's some recommended action items to follow. These are just recommended. You can listen to me or not. that's for you. All right. If this is small, you can on your screen, there's on the right hand corner, there's a way to zoom in on your screen so you can see it. This presentation will also be posted, so don't think that you have to hurry and write all these down. So we adjusted the family and in-home caregiver definition to reflect that a family member is not always responsible for being the nurse and to assume a portion of the care when the staff is absent. So we had heard that there were agencies that were requiring family members to waive the emergency plan, and that they were always the emergency plan, and that is not the case. We want to make sure that the home health agency is aware that it's their responsibility to provide backup care and to ensure, and that the family member is there to ensure that there's an advocate for that member, an assistant when there is an emergency situation, like calling the agency when someone doesn't come show up for their shift, or what, that the environment is safe. So this is not to waive any responsibility of our staff for the home health agency. Updated the term physician to include the allowed practitioner, and this matches a change with the CMS, the Center for Medicaid and Medicare language, so that now you can have an allowed practitioner as long as they're revalidated with the Department of Healthcare Policy and Financing and listed on the claims correctly, so that home health agencies can get paid. We've also updated language and the definition, as well as throughout the rule, that care can be provided in the home and community, so that PDN services can be provided in any place that normal life activities take place, as long as there's no duplication of services. And this would include if traveling out of state, as long as the nurse's license is valid in the location that the services are provided. Next slide. Just raise your hand if you have a question. I'm trying to get through this because there's quite a few slides. So next is the benefits and eligibility section. We did swap those in the rule. So the criteria for services comes first. So the term technology dependence and that criteria for children was removed. So that criteria is based on member age is clarified, and those under 20 just reads the EPSDT regulation in that language. And we removed more of the restrictive language to be more encompassing of all the member conditions. Previously, it was very specific on O2 readings and things of that nature. So we have just based it now on that EPSDT and program integrity rule language around medical necessity. Pediatric and adult PDN benefit max hours were specified that pediatric hours can be up to 24 hours a day, while the adults are at 23 hours. We also highlighted in this section that their home health agencies have the ability to use short-term revisions to help members through acute issues. That revision has to be submitted through a Trezzo, but that can help, after surgery and the member is recuperating for a period of 3 months and they need additional support, that to utilize that to support our members fully. Circumstances where PDN is not allowed was clarified and streamlined and removed a lot of duplicate language. And I just highly suggest that home health agencies are familiar with this section. I know there was a request from the stakeholders to remove this altogether, but we do have to have some boundaries in the benefit. We removed the outdated application process and the hospital pre-release directions. That application process wasn't being utilized, and we saw that it was sometimes slowing down the process of members being discharged to a home health agency. So we did abbreviate those discharge procedures, but we did keep them in there so that the hospitals do have some responsibilities when discharging a member of the high needs. Provider requirements. We added the provider eligibility criteria and provider agency requirements, and this directly matches the home health regulation of 8.520. The agency classification, a Class A skilled agency, is the same for home health agency and PDN. So the eligibility and the provider requirements are exactly the same. We specified the role in providing PDN services for the home health agency and the responsibility for them to adequately train staff and to partner with families. And there's specific language around cultural and disability competency that is included. So I highlighted that so that home health agencies ensure that they have that information in their training, and that nurses are physically and mentally able to provide the care that is needed for these members. We had some clarity around roles and responsibility for really anyone who's involved in the member's care. So the member and the family do have some responsibility, like I said before, being that advocate, making sure that the home environment is adequate for all the equipment that may be needed, there's roles and responsibilities for the home health agency, as well as the physician, that should work in partnership with the home health agency and the family member. They have a very large role in helping with directing the care. So we have outlined that they have some responsibilities as well, to communicate, and to really partner with everyone to make sure that the member gets the care that they need. We have clarified a designation of a case coordinator, and that is your case manager in the home health agency. It's the nurse that is going to go out and do all the assessments, is going to help partner with the physician, get orders as updated as they need be. What you call this person in a home health agency, it doesn't matter. It's just that one central person that is responsible for that management of the PDN services and knowing that coordination within the agency. Any questions at this point? Okay. Next is the prior authorization requests. So we changed the change of, that's a lot of words of change. The change of provider process was updated to simplify the steps for providers and members when members want to make a transition to a new home health agency, and that way the PAR follows the member. So the change of provider form needs to be completed. You can take that to your new home health agency. They will complete a 485, and that change of provider and that 485 will be submitted to Atrezzo and Essentra to update the PAR, to change the PAR provider on record from the old agency to the new agency. We won't do another medical necessity review unless there is a change in the request. If you're increasing hours or something else has changed, then we will need to go through and do a new medical necessity review and ask for additional documentation that you would submit with any new request or revision. We've added information on how more than one home health agency can provide PDN services to one member. We realize that due to staffing issues that the primary home health agency may need to coordinate with another home health agency in order to meet needs fully for the member. PAR needs to clearly state which agency is providing what service and who is responsible for the supervision of the staff, and each agency will need to have their PAR for their portion. In the rule at one point during the revision process, we had added a bunch of documentation that could be included, and then we thought that that was overwhelming and it didn't need to be in the rule. And we wanted to have a document or a resource list that we can update as we go, kind of a live document of a resource for providers and members. And so that documentation resource checklist that is on the bottom of the crosswalk gives you what it is absolutely required, and then suggestions for what could be helpful to include with your prior authorization requests. And we will update this as we hear back from the community on what documentation needs to be added or suggested, or what we're seeing as missing, or what have you. Timelines. So we included the timelines for utilization management into the rule, including the process for appeals related to any PAR request for private duty nursing. And so there is a chart which I believe is the next slide. Can you scroll down and then we'll scroll back up? Okay, so this is our timeline of events. And so you can see the initial PAR is from the 10 days from the start of care. Renewal PAR is up to 1 year. Basically, try to include all the different things that could happen to a PAR during its life and the time frame of when documentation needs to be submitted, and highlighted what changed. So I want to highlight here that the peer-to-peer process and reconsideration, the home health agency can request this after a denial or a partial denial, and that's 10 days. That usually happens within 10 days after the home health agency requests that. We also have the continuation of benefits after denial was changed from 15 days to 30 calendar days from the date of denial. But you must have had a previous approved hours to continue. If this is a brand new first time, there is nothing to continue. So there is no continuation of benefits. So we can go back up one slide. Okay. So I went through all of that on the timeline. We can go through the process flow chart if you have that up, Paul.
I do also have to swap screens again here.
Sorry.
Real quick. Give me a second.
Any questions so far? It's a very quiet group. Okay. Again, you can zoom in on the far right corner of the screen. There's a plus sign. And this is just basically a flow chart of what happens to that request, what happens, all the things that need to happen for your services to be approved. I thought sometimes I'm a very, very visual person, and I thought that this might be helpful for sharing with members who are new to this process. Would love feedback on this after you guys have some time to digest it, and you can send that to the home health inbox if you have any questions or need clarification on this flow chart. Okay, back to, I'm sorry, Paul. I'm making Paul work today.
We got it. We got it.
Okay, there's our chart. One more. Okay, reimbursement. We expanded the language around group rate and group billing. We need to ensure, home health agencies need to ensure that the nurse to member ratio will not exceed what can be safely cared for simultaneously by one licensed nurse, depending on that member acuity and any additional support in the home. And this is something that CDPHE will be looking at when they do home visits for surveys, is that we're making sure that member safety is of utmost priority, and that we're not staffing more members to one nurse than are logistically safe for that one nurse. And this is for the nurse as well as the member to be safe, and that ensure that care is being given as the plan of care directs. We also added language around purposeful activity and awake hours of the nurse. So care plans and staffing patterns need to account for staff not being allowed to sleep at any time during the provision of the PDN services. And we will look at, when the survey or post-payment review, we will look at those nursing notes and the care plan and make sure that they match. So if you submit a PAR request for nighttime hours for G-tube feedings, then we need to have the nursing notes that match that nighttime time frame and what is being the cares that are being delivered during that time. We added language around the maximum hours of day a nurse can work to match what door regulations, Board of Nursing for member and nurse safety. So home health agencies will need to know that their staffing patterns need to ensure that no one nurse is scheduled for over 16 hours per day, except in rare documented emergency situations. So again, this is safety for the member is of utmost priority. So that was a lot that I just spewed out at you. Any questions? Okay. So the next steps, so we're going to update the website, as I said, the Private Duty Nursing website with this presentation, as well as the resource guide and the crosswalk. We will update the FAQs on the PDN website with the questions that we get from you all. And then we're continuing to host open office hours. So we can provide on-the-spot technical assistance. No need to sign up for that. You just come when we're there and ask your question. You can also submit questions to the home health inbox. And we're going to continue to collect the feedback, monitor effectiveness of these changes, and we'll continue to display the data on PAR approvals for public view on the PDN website. Yes, Paul.
And just a quick plug on those office hours. Our next office hours will be next week on the 9th. We run them the second Tuesday of every month, and they'll be from 1 to 2, roughly about 2 o'clock. We have, I think, until 2:15 blocked off. But we'll be there Tuesday about 2 o'clock, and you can get all the information on either the home health website or the Private Duty Nursing website.
Thank you. Okay. Hi, Claire.
Hi. So I'm Claire Dixon from Colorado Legal Services. I just wanted to go back and ask you about the slide that you had presented regarding the family member's responsibility to provide some care. Can you guys go back to that slide? And I think you were trying to clarify that the family member's role is to act as an advocate.
Correct. Yes. So what this was around is that we had some home health family members to waive the agency their responsibility of providing emergent or backup care,
Right.
which is not the intention of the rule.
So I had, right before the meeting, I had tried to download the rules that you had presented for final adoption to the Medical Services Board, and the 8.540.5.D, point 1, point A, that language, and maybe I'm looking at the wrong version, still says that the family member must be able to assume some portion of the member's care when the agency staff is not available. So maybe I'm looking at the wrong version, but that doesn't seem consistent.
So there is some responsibility for the family to provide, make sure that the environment is, make sure that it is working, but we don't expect them to be the nurse. So if a home health agency says we're going to be in your home 24 hours a day, then the home health agency needs to have that plan to staff that. If there is an emergency that, maybe the nurse is sick or the nurse has an accident, there is somebody available with the family or live-in caregiver or a caregiver assigned to that person that can do the basics to make sure that that member is safe. Does that clarify?
Yeah, I'll go back and try to find the final version of the rule.
Okay. Any other questions? Hi, Irina. I think you're muted. There you go. Oh,
So, my computer for some reason. Sorry about that. Christine, hi. Do you mind going to the slide where it talks about the language, about the group, group setting?
sure. That's under reimbursement. And what was your question?
But I guess the question, like, what would you recommend, like, to instruct the agencies to identify what is safe? It's a little bit vague, like, how do we tell the providers what the criteria that they should be looking at?
Yeah, so this is going to really depend on the home health agency looking at each of the members and the acuity. We can't just say 2 to 1 or 3 to 1, because those 3 patients or 3 members could look completely different in each agency, and depending on the nurse that is assigned as well. So, making sure that needs can be met by one person, that if you have a lot of a very high needs that needs the attention of that nurse on a constant basis, due to how fragile they are, but we don't then also have another member that needs care and jeopardizes either one of them. So it really has to go on the clinical expertise in the home health agency to ensure that each member, they're looking at them clinically, and making sure that the support in the home is meeting the needs safely. I wish I had a magic number, but
Okay,
everyone
makes
looks
sense. And
different.
nothing specific. No. Yeah, exactly. I understand. I just, like I said, that could be something of a confusing, area. So, but just helpful answer. Thank you very much, Christine. I appreciate it.
Mhm. Any other questions? So you can contact us through the home health inbox, which Paul has put in the chat. And then again, we have open office hours next week. Anything comes up in the meantime. All right. Well, I'm going to give you guys back about 20 minutes your day. I appreciate you attending, and we'll have this up on the website as soon as we can.
Thanks, Christine.
Thank you all so much.
Thanks. Thank you.
Thank you.